Good evening and welcome for the grand rounds. We apologize for a few minutes of technical delay. We are ready to get started. Let's get with the first section, and that would be the MOC CME credits. I'm going to share my screen and have that taken care of, and then subsequently we'll have the introduction of the speaker and also all right. So the cardiology grand rounds for tonight is going to be hosted once more at the YouTube website. For the CME credit for this session, please text 20410 to the number 888-816-4893 as an SMS message. And for the MOC credits, please use the room code Future 2024. The link will be displayed back in. You can use also the barcode. You can scan it and get in. This is available for 12 hours after the presentation. You can go ahead and answer the questions, and if you get them right, it goes as an ABIM credit in your ID. Very good. So with those two steps, we are now ready for introducing our grand round speaker. And I'm going to bring in Dr. Kamu Maganti, who's going to go ahead and introduce our grand round speaker and also bring in our second panelist for tonight, and that is Dr. Yasmin Hamrani. Kamu.
Thank you very much, Dr. Sengupta. It is my pleasure to introduce Dr. Walid Ahmed, one of my good friends. Just a little bit about him. He has graduated as one of the top 2 students in his batch from Aga Khan University Medical College in Karachi, Pakistan, where he received his MBBS degree. He then did his internal medicine residency at Duke, as well as New York Presbyterian Cornell Medical Center. He then completed a postdoc fellowship in cardiovascular research at Brigham and Women's Hospital. He subsequently did a cardiology fellowship at University of California in San Diego, as well as a fellow in cardiac imaging at Mass General Hospital. One of his primary interests have been imaging, predominantly within the CT and CMR. He has published in that same space, predominantly looking at plaque characterization. And as a reader recently, he has moved to Houston Methodist Hospital. And he is doing some interesting research, especially with plaque characterization. He has received multiple awards and has published widely. We are in for a great treat between Dr. Hamirani and Dr. Ahmed. So, Walid.
Thank you very much for the introduction. So I'll go ahead and share my screen. Can you see it?
Yes.
Everybody can see my screen? Okay. All right. So thanks for the introduction again. We'll get started. A lot of very interesting things to talk about. I'm currently at Houston Methodist Hospital. I'm a multimodality imager, but I probably spend the most amount of time reading coronary CTs. And I'm also the director for the cardiac CT research over there. So I do not have any disclosures. So this is how I would like to plan my talk. I'll talk very briefly about the past, which is 3 landmark trials in cardiac CT. I'm not going to spend a lot of time on that because we have a lot to talk about what's coming in future. We'll talk about where we stand with respect to FFR CT as of today. New hardware technology, the most exciting thing in recent years being photon counting CT. Current trends in CT reporting and implementation of CAD-RATS 2, which most institutions are adopting currently. And then very, very exciting, moving on to plaque characterization with CTA and the role of AI, machine learning, and radiomics in this space. And finally, we'll talk about imaging markers of vascular inflammation, something called Factor Attenuation Index, FAI, and then just end with evolving concepts and coronary CT indications. So going over the 3 landmark trials, I'll talk about ROMICAT2, PROMISE, and SCOTHART. ROMICAT-2 was the study that established the role of coronary CT in chest pain patients presenting to the emergency department. Now, this was published back in 2012. It was a multi-center trial, and their primary endpoint was length of hospital stay. They randomized patients to standard of care versus a strategy that employed doing coronary CT from the emergency room, but this was only during daylight hours. And their primary endpoint did show a statistically significant difference, with the mean length of hospital stay reduced by about 7 hours in the group that was assigned to coronary CT. So the next big one was the PROMISE, published in 2015. Now, this was in an outpatient setting, with a randomized trial of chest pain patients assigned to a strategy of either initial anatomical testing with CT or functional testing, which could include exercise EKG, nuclear stress testing, or stress echo. And their primary endpoint, composite endpoint, was a composite of death, MI, hospitalization for unstable angina, or major procedural complication. And after a median follow-up of about 25 months, there was no statistically significant difference in their primary endpoint between the two groups. And it's always bothered me a little bit how the stated their conclusions in the study. They said in symptomatic patients with suspected CAD who required non-invasive testing, a strategy employing initial CTA compared to functional testing did not improve clinical outcomes over a median follow-up of 2 years. But it's more like it was at least not inferior, because this field was still developing, and these are their curves for the Kaplan-Meier curves for the primary endpoint. And now this is probably the most important one of the three. This is from Scotland, published same year in Lancet in 2015, the SCOT-HEART trial, which was different because this was based on chest pain patients that were referred to specialized cardiology clinics for evaluation of suspected coronary artery disease or angina. So the trial was aimed to assess the effects of a strategy employing coronary CT on the diagnosis, management, and outcome of patients being referred to a specialty cardiology clinic. This was done across 12 cardiology chest pain centers all over Scotland. And primary endpoint is very, very different. This was the confidence or the certainty of the diagnosis of angina secondary to coronary heart disease at 6 weeks. So smaller trial than PROMISE, about 2,000 patients in each arm, PROMISE at about 5,000 in each arm. And what they showed was that at 6 weeks, the CTA reclassified the diagnosis of coronary artery disease in 27% of patients. So just focus on the red bars on the left. So for example, at baseline, if 7% of patients who had a probable diagnosis of coronary artery disease in the CT group had that change to a definitive diagnosis of CT at 6 weeks, and that was not seen in the standard care arm. And then the other important takeaway from the trial was, of course, that once you visualize plaque on coronary CT, that is going to change management decisions even with non-obstructive disease. So the CTA changed plan investigations more significantly in the CT group, and more of those patients were started on preventive treatments, including statins and anti-anginal treatments. Very importantly, probably more important than the initial SCOT-HEART trial is their 5-year follow-up report in New England Journal in 2018. Where they reported the data after a median duration of follow-up of 4.8 years. The primary endpoint was death from coronary artery disease or non-fatal MI at 5 years. And very, very powerful results that showed that there was a statistically significant difference in patients who had a initial strategy of coronary CT. So this is the cumulative incidence of deaths from CAD or non-fatal MI, standard of care, and coronary CT arm. And the other important thing they showed is, there's always criticism that performing CT leads to more revascularization and coronary angiograms, but that is only true in the initial few months up to a year, because they showed that at 5 years, the rates of invasive coronary angiography and coronary revascularizations were actually similar between the two groups. So this is a very important conclusion that use of a CT employing use of a strategy employing CT resulted at significantly low rate of the primary endpoint of death from CAD or non-fatal MI without resulting in a significantly higher rate of coronary angiography or coronary revascularizations. So with that passed, we'll move on to where we stand with respect to FFR. As you know, CT-derived FFR is at this point in time is widely employed at any major CT program. The parameters that affect plaque fractional flow reserve are the degree of coronary stenosis, of course, size of the coronary arteries, as well as the myocardial mass supplied by the stenosed artery. HeartFlow is the major vendor, which is FDA approved, that all of us use. And their algorithm for computation of CT-derived FFR involves an integration of complex fluid, computational fluid dynamics along with the anatomical data, leading to creation of this 3D anatomical map with different pressure values along the length of each of the arteries. This is a nice review by Dr. Hatchett of really showing you all that goes into calculation of the CT-derived FFR with the computational fluid dynamics, construction of a 3D coronary tree with coronary artery segmentation, calculation of microvascular resistance. These are the Navier-Stokes differential equations, which are basically based on conservation of the blood mass as well as the blood momentum of blood across the stenosis. So very sophisticated stuff. Now, there have been numerous diagnostic accuracy studies comparing FFR-CT to invasive FFR, that being the gold standard. And this is one of the most important ones published in JACC in 2019. And this was a post-hoc sub-study from the Pacific trial, and they looked at the diagnostic performance of FFR-CT and compared it with just coronary CT alone, SPECT and PET for ischemia diagnosis. Very unique trial because the 208 patients in this trial had all three things done to them. They had a cardiac CT done, they had a PET done, a SPECT done, as well as an invasive cath with a calculation of invasive FFR values. And the threshold, which we use in the cath lab, of course, for a significantly low FFR was set at less than 0.8. So when you look at the ROC curves for the discriminative ability of these different modalities against invasive cath FFR of less than 0.8, here's SPECT. In the red is the CT alone. A little bit better than that is the PET, and then of course the ROC curve has the best AUC when you employed a strategy of CT plus FFR. This is on a per vessel basis. Now they do report on a per patient basis where actually PET was slightly better than FFR CT plus CT. So the conclusion being that FFR CT showed higher diagnostic performance than standard coronary CT, SPECT, and PET for vessel-specific ischemia, but PET had a favorable performance in the per patient analysis. So at this point, we have a number of studies, Discover Flow, De facto, Next, Pacific, all of them showing that inclusion of CT FFR in the interpretation increases the specificity of the coronary CT and the accuracy without really sacrificing the sensitivity. And moving on to emerging concepts of how we should use FFR-CT. This is a nice study from Pam Douglas's group, published just last year in JAMA Cardiology. And they compared two different strategies. One was called the precision strategy, and the patients were randomized to one of these two strategies. The precision strategy was a strategy in which they calculate the PROMIS risk score, which has been developed using the data from the PROMIS trial and has been published previously. And so the precision strategy employed that score, and the other group was randomized to the usual testing. This was a randomized clinical trial with a median duration of follow-up duration of 11.8 months across 65 North American and European sites. This is the PROMIS minimal risk score. And as you can see, it includes the age, gender, ethnicity, along with a host of other coronary artery disease risk factors. This was the trial design. About 2,000 patients were randomized to the two groups. In the precision strategy, if they had a low PROMIS risk score, any kind of testing was deferred. But if they had an elevated risk, they had a coronary CTA done with selective FFRCT for any stenosis that was between 30 to 90%. And in usual testing, the clinicians decided what testing they wanted to do. They had a composite primary endpoint, which is a composite endpoint of safety, death of non-fatal MI, as well as clinical efficacy, which was invasive cath without obstructive coronary artery disease. So they were able to show a statistically significant difference in their primary endpoint. But please note, it was driven primarily by the rates of invasive cardiac cath without obstructive CAD. So in the precision group, the rates of cath showing no obstructive coronary artery disease were significantly lower. So the rates of death or non-fatal MI were actually pretty similar in the two groups. And this is these are the CT-FFR values in the precision group among patients who underwent revascularization. The majority of the patients who underwent cath and subsequent revascularization had a CT-FFR value of less than 0.8. So no difference between death or non-fatal MI. As I mentioned, the difference was largely driven by the low rates of cath showing no obstructive CAD in the precision strategy group. So the trial is important because it really makes us think about FFRCT as not just a tiebreaker to when to call significant stenosis or not, but really highlights its role as a gatekeeper to the cath lab. And in the discussion, they note that the previous trials have all been criticized for CT leading to more downstream testing, leading to more revascularization and cardiac caths. But this trial actually had the opposite finding, that CT using this precision strategy was a more clinically efficacious way of making decisions. And this is likely because the incorporation of selective FFRCT in the study. Unlike previous trials, this trial actually showed a decrease in the unnecessary diagnostic catheterizations. So another area in which CT-FFR thinking is evolving is in patients with multi-vessel complex coronary artery disease. Just briefly, this is a publication from the Syntax 3 Revolution trial. This study was based on 223 patients, and they had CT done in these complex three-vessel disease patients with CT-FFR. And that data was available to the heart teams, two different heart teams, in a randomized fashion. And these heart teams had to make a decision whether to send these patients to CABG or to multi-vessel PCI, or whether they thought that each option was equally good. And the inclusion of FFR-CT information resulted in reclassification of 14% of patients that were thought to intermediate to high risk based on their Syntax score to a lower score. So the conclusion was that in patients with three-vessel coronary artery disease, a non-invasive physiological assessment using CT-FFR can help heart teams' decision-making in procedural planning. Another application of FFR-CT that's being developed now is for procedural planning for the interventional cardiologist. There are these CT revascularization planner tools that are available, which can predict what the FFR-CT is going to be post-procedure in someone undergoing PCI and stenting. In this review by Dr. Lipsick, they're showing that example, this lesion in the mid-LAD with low FFR-CT values distal to the lesion. If a stent were to be deployed, this is the modeling of the FFR-CT values that you're going to see post-stent deployment. So in 2024, FFR-CT reporting should be standard in these 30 to 90% stenosis patients and not optional. But some key consideration not to forget, it does assume nitroglycerin administration. It does involve giving heart flow an exam with reasonable quality, because some of them will be turned down. Its role is evolving, but still limited in patients with 50% left main or critical three-vessel disease. And remember, FFR-CT can still be performed in non-stented vessel in a patient who has stent in one or two other vessels. And one newer thing that's developing in the FFR-CT world is moving beyond computational fluid dynamics to newer ways of calculating FFR-CT that are more efficient and can be done at your local workstation. And these are machine learning models that do not go through the entire computation using computational fluid dynamics. And this is one paper that showed one of these machine learning models' performance. This is from Circ Cardiovascular Imaging in 2018. So they argue that CTFFR using computational fluid dynamics is computationally demanding, which it is. And they proposed the development of a new machine learning CTFFR algorithm, which is based on a deep learning model, which can be performed on a regular workstation. So they had data from 5 centers in US, Europe, and Asia for this study, a total of 351 patients, totaling 525 vessels with invasive FFR invasive FFR comparison available. And so like any machine learning model, what you have to do is do this supervised learning approach, where the machine is trained to develop an algorithm, a prediction algorithm based on anatomic features which are tested and trained against a ground truth. So you have to feed the machine the ground truth training data. And in this study, it was 12,000 synthetic 3D coronary models of various anatomy and degrees of coronary artery disease, for which computational fluid dynamic based CT-FFR values were computed. So what the machine is learning is the machine is actually learning how to predict an anatomical based CT-FFR that would rival or correlate with one that is calculated using the computational fluid dynamics. And it gets really complicated if you look at the supplement in the paper. These are all the variables, the 28 input features that ended up going in the final model. They showed very good correlation between the machine learning based CTFFR compared to the computational fluid dynamic based CTFFR with an R value of 0.99. Good correlation between the machine learning CTFFR versus the invasive FFR. And then finally here, the AUC curves for the discriminative availability of the computational fluid dynamic based CTFFR in red and the machine learning based CTFFR in green against an FFR value of less than 0.8 on invasive cath. And the AUCs are actually identical, 0.84 for both. So this argues that these models can be just as good but easier to implement than the ones with computational fluid dynamics. And I'll show you briefly how Clearly puts out the reports now. That's one of the vendors, and actually the ischemia or the CTFFR information they give is based on one of these anatomical machine learning models. Moving on to hardware technology that has evolved and is evolving, photon counting CT has been very exciting. I'll just go over briefly what that is. So remember, when we set the tube voltage in our CT scanner at, for example, 80 kV or 140 kV, it doesn't mean that that is the energy of all the photons. 140 kV, if it's set at 140 kV, 140 kV is going to be the maximum energy of any photon coming out of that tube. And there's actually a range of energies of the photons that are coming out. And the traditional CT scanners have had detectors which are called the energy integrating detectors, or EIDs. I got these slides from the Siemens website, where they do a very nice job of explaining photon counting CT. So these traditional detectors have these solid state scintillation detectors separated by septi. And when the photons strike, there is a light emitted, which is converted to an electrical signal by the photodiodes. And for each one of these detectors, the signal is basically an integration of the energy of all the different photons that are striking this particular detector. So a lot of that information of individual KVs of the individual photons is lost. So it's averaging that signal. Photon counting detector CTs are inherently different in design. You have the detector as a semiconductor, usually made of cadmium telluride for the Siemens scanner. And every photon that strikes this is converted to an electrical signal, and the electrical signal or the voltage of each signal is proportional to the energy of the photon that is striking the semiconductor. So all that information is preserved. There is no integration or averaging of the energy values done. So actually the signal generation is faster. And what has allowed this technology to develop is two things. One is these newer semiconductors that have been developed over the years, as well as the improvements in software, because the software and the computers need to be able to process a lot more information very quickly. Um, the one other difference I would point out is there are no septa, which allows for a higher spatial resolution with photon counting CT, which is key in coronary CT, because in order to increase the spatial resolution and the energy integrating detector, you have to come up with more septa. But there becomes a point where you cannot increase the number of septa to decrease the detector size, because it becomes geometrically inefficient for the scanner to do the scanning. It can break down in the photon counting CT. The machine can break down the energy in the photons in different bins and count how many, for example, were there in the 50 to 100 kV range. And it can set, you can set a threshold where all the photons below this energy are not gonna generate any signals to get rid of the electronic noise. So because of the need for the septa, as you know, the spatial resolution for most traditional CT systems, the energy integrating detectors are around 0.5 millimeter. But because there are no septa needed here, the spatial resolution is much better for the photon counting CTs, down to a pixel size of 0.22 millimeters or lower. And so there are two major advantages of the photon counting CT, what allows us to do one, and both benefit coronary imaging. One is the spectral imaging, and and the other is high spatial resolution. Spectral imaging basically means that you're able to reconstruct images at a particular kV. So for example, you can construct images by getting rid of all the iodine signals. So you don't even have to do a non-contrast scan before your actual scan. And you can construct images at a mono kV range, and that leads to better stenosis grading and reduced contrast dose. The bigger advantage for coronary imaging is the high spatial resolution. As I mentioned to you, it's down to 0.22 millimeters now. And of course, that leads to improved small vessel imaging, less calcium blooming, improved stent imaging, and improved visualization of plaque characteristic, leading to increased diagnostic confidence. All the different vendors are coming up with their version of photon counting CT. Siemens is probably ahead of the game. About more than 80 of these from Siemens installed to date in the world. This is one of the first reports in radiology looking at the experience of doing coronary artery imaging with photon counting CT. They looked at 14 participants with coronary artery disease who underwent CT with both systems, the photon counting CT as well as the energy integrating detector. And the systems that they used were actually made by Philips. This is not Siemens in this study. So as you know, the reconstruction parameters are different. Photon counting CT, you have a 1024 matrix, 0.25 millimeter slice thickness, versus for EID CTs 512 matrix, 0.6 millimeter slice thickness. Here you can see even the small septal branches much more clearly. The non-calcified plaque boundaries here in the traditional from the traditional CT are not that sharply defined, but here you can see it much more well-defined. Here's an imaging for a stent, and you can see how much better the definition of the stent struts is with the photon counting CT. You can even see this outside calcification disrupting a little bit of the struts. And then here's an example of a mixed plaque. Again, much better defined. This is the calcified part, is the non-calcified part, but here you can see it much more clearly. The big advantage also being less blooming artifact, which is the most painful part of reading CT. So you get that with a lot of calcification. And you can see in this region marked E here, where there is a lot of moderate amount of calcified plaque. Here with photon counting CT, the lumen is still clearly visible, whereas with the EID CT, maybe someone would call this significant stenosis because the lesion, because it's not, the lumen is not as clear. So moving on briefly to what is CADS-RAT latest 2.0 reporting. This was published in 2022. The initial CADS-RAT was published in 2016. So this goes over how we should report coronary CT for stenosis grading, plaque burden, and then certain modifiers that have changed. There is no difference in the stenosis grading between the two versions. there is a system now for grading plaques and then a few new modifiers. One is I for ischemia, which is based on CTFFR, certain E modifiers, the exceptions, I'll show you what those are. And then the modifier V, which used to stand for vulnerable plaque, has been replaced with HRP, standing for high risk plaque. So degree of stenosis hasn't changed. It's the same as before. We go minimal, mild, moderate, and severe stenosis. Here are the different categories of plaque, P1 to P4. And then these are the modifiers, ischemia plus for abnormal CTFFR and ischemia minus if it's normal. Here are some examples of the E modifiers, exceptions, which are these different pathologies: coronary dissection, anomalous origin, coronary artery aneurysm, vasculitis, fistula, and other causes. And they also have in their paper guidelines for stable chest pain patients as well as for acute chest pain patients for different management considerations based on where the CADS, RAD score falls. It's pretty intuitive. I think as clinicians, most of us do that anyway. All right, so moving on to a bigger area, which is very exciting, plaque characterization on coronary CT. This was one of the seminal original papers that really defined what are high-risk plaque features at coronary CT from Japan. This is back in 2007 in JACC, where they looked at about 32 patients who had MI or ACS and compared them with 30 patients with stable angina and looked at the plaque characteristics of the lesions causing MI. And they found that these three features were strongly associated with plaques that were causing acute coronary syndromes. And those were positive remodeling, which is the outward growth of the plaque, a non-calcified plaque with Hounsfield units of less than 30. So you can have non-calcified plaques with an intermediate Hounsfield units 30 to 150, which are more of fibrous plaques. And these ones, which are called the LAP or the low attenuation plaques, have an Hounsfield units of less than 30, and they are high risk because they're thought to have a large necrotic core. And then the third parameter associated was spotty calcification. There was also been description of this napkin ring sign, which is a hyponatriated area, which correlates with the lipid core surrounded by a higher attenuation area. And so these are called the HRP or the high-risk plaque features, the positive remodeling and the large necrotic core burden. We cannot really look at thin inflamed fibrous caps on coronary CT. That is something that you would need OCT for. With respect to plaque characterization, first, does it have any correlation with outcomes, or is there any prognostic data for that? And this is one of the most powerful studies using the data from the Scott Hart trial from Circulation 2020. This is a post-hoc analysis of the Scott Hart trial data, and they did quantitative assessment of atherosclerotic plaque subtypes using a semi-automatic software. In this case, they use AutoPlaque, which is one of the plaque characterization software developed at Cedars-Sinai. And you can see the software quickly picks up all the non-calcified plaques and codes them as red. But then beyond that, it's gonna differentiate them into low attenuation and very low attenuation, which is less than 30 Hounsfield units, which is these orange plaque in this modeling. And they showed that the low attenuation plaques were the strongest predictor of myocardial infarction based on the outcomes data from the Scott Hart, irrespective of cardiovascular risk score, coronary artery calcium score, or coronary artery stenosis. So very strong predictive value. This is a report from earlier in 2015 from the same Japanese group, but this report actually has one very important concept which feeds into what we want to do in future with respect to plaque characterization and plaque volumes, which is why I wanted to mention this paper. So they looked at 3,000 patients that were undergoing coronary CT and followed them for a mean duration of 3.9 years. And they looked for the presence of high-risk plaque features and for significant coronary stenosis. But the important thing is that for this study, they had a subsequent CT available in 449 patients. So of course, they showed that high-risk plaque features are associated with worse event rates, but they also showed, which was not shown before, that plaque progression was an independent predictor of acute coronary syndromes in future. So this nice review of Dr. Narula that talks about subclinical atherosclerosis to plaque progression, acute coronary events really challenges this notion that we've all been taught that this is really true that most acute coronary events result from a rupture of mildly stenotic plaques, because the CTA data have confirmed that lesions that do not progress rarely lead to events, regardless of the degree of luminal stenosis or the plaque morphology. And now this is very important because you can follow the plaques over time for progression or stabilization or regression, and that will tell you that the patient's overall risk is decreasing. But also, many of these softwares can now do, a following plaque volume over time can be meaningful, because irrespective of whether someone has an individual lesion that's significant more than 70%, plaque progression by itself is a bad predictor. It predicts future ACS. So should we move beyond the holy grail of identification of vulnerable plaques to calculation of total plaque volume and what that is doing in an individual patient over time, progressing or regressing? This is a nice review in JCCT by Dr. Williams and Hatchett, and they talk about how there is a move from qualitative to quantitative coronary plaque analysis using different semi-automated softwares. But all of these softwares are basically doing is they are delineating the boundary between the lumen and the vessel wall, as well as the surface of the atherosclerotic plaque or the epicardial plaque. And then it's calculating the plaque volume as the area between the lumen or the space between the lumen and the outer wall boundaries. These are all the different vendors that are offering this. Shore Plaque, QNGO clearly is making a big impact in this field. There is Elucid Vivo out of Boston, and then Autoplaque is the one that was used in the study I showed out of Cedars-Sinai. We do have nomograms available for plaque volume now. This data was just published this year in February 2024 by Dr. Lipsick's group in JACC Cardiovascular Imaging. They took quantitative plaque assessment data from almost 12,000 patients from 29 healthcare systems in US and Canada. The plaque volumes were calculated using a fully automated AI-driven software from HeartFlow called QCPA. And these are the nomograms they publish in their paper, which is the different percentiles for both men and women over different ages. Another important finding from the paper is that when they looked at the stratification of different kinds of plaques, calcified versus non-calcified by different age groups, they saw that in younger patients, less than 45 years of age, the prevalence of the non-calcified plaque was more compared to older patients. And this ties into what we'll talk about towards the end with CT for primary prevention. This is how a report from Clearly looks like today. So it'll give you the total plaque volume as well as the volume of the calcified and non-calcified plaques, the degree of stenosis, and it will also give you that CTFFR that, remember, I was telling you is calculated using anatomical deep learning algorithms, not computational fluid dynamics. Now, a step further on plaque characterization, which is, all these semi-automated software still need some manual corrections, and you have to create center line, and you agree with them. So this study by Dr. Lin in Australia and Dr. Day at Cedars-Sinai last year from Lancet Digital Health looked at a deep learning model that can very quickly derive plaque volume and stenosis severity. So they had data available from 9 different cohorts undergoing CT at 11 different sites. So for machine learning, they were assigned to the training sets and the test sets. And then eventually the model they developed was applied to the Scott Hart data to assess its prognostic value. So these are the different cohorts that were available to them. These were the training cohorts to use to train the machine, and then the test cohorts to validate it. Expert plaque measurements was done by the level 3 CT readers in the study using the Autoplaque software from Cedars-Sinai. And as I mentioned before, when you have to train an AI deep learning model, you have to feed it the ground truth. And the ground truth here was expert reader coronary segmentation with information on vessel volume and plaque from thousands of studies. So they showed that there was very good correlation between the total plaque volume from the expert readers versus using the deep learning model, which was much faster. It took only 5.6 seconds versus 25.6 minutes taken by experts. And then it also had prognostic value when applied to the Scott Hart data. They were able to come up with this threshold value for plaque volume of 238 millimeter cube, and below which there was a much lower risk of fatal or non-fatal MI. And a step further, the same group has also published on radiomics, which I'll briefly touch upon. So radiomics is evolving science in a way that looks at quantitative parameters like shape, intensity, and texture to extract more information from medical images so that you can have more precise, deep phenotyping of disease. So the same authors have published this also last year in JACC Imaging, radiomics-based precision phenotyping to identify unstable plaque. And the premise for the study is that, yes, we all know that attenuation-based plaque characteristics are important and correlate with prognosis and coronary events. But beyond these conventional parameters, there may be latent morphological plaque features that are not captured by our current coronary CTA analysis techniques, and that's where radiomics comes in. So in this study, they looked at 60 patients with acute MI who had a coronary CT done before cardiac cath and compared those CTs to 60 outpatients with stable coronary artery disease. And here are the ROC curves for the performance of the different models for discriminating culprit lesions that caused MI. So here's just looking at the high-risk plaque features. The red includes high-risk plaque features plus the plaque volume. And blue, which was the best model with the best AUC, is high-risk plaque features plus plaque volumes plus certain radiomic features that they found were associated with the culprit lesions that are likely to cause ACS. Here's a ranking of the different features in the final machine learning model that had the best AUC. These ones are the radiomic features in orange, then green are the quantitative plaque features, and then these blue ones are the qualitative plaque features. So it gets more and more sophisticated, and they come up with these clustering dendrograms for the different radiomic features. For example, these clusters in green here are seen in high-grade stenosis that are not causing ACS. These features in blue are seen in both plaque types, and then in pink here are features, radiomic features seen in culprit lesions. And so the conclusion was that culprit lesions causing MI may have distinct radiomic signatures compared with lesions that may be high grade but are in stable CAD patients. And so vulnerable plaques may be identifiable by this cutting edge radiomic modeling or deep phenotyping, precision phenotyping. And lastly, we'll talk about imaging marker of inflammation, the fat attenuation index. As we all know, atherosclerosis is a disease of inflammation. It's a complex lesion with a lot of interplay between different cytokines, macrophages, lipid core. And this index has been developed called the perivascular fat attenuation index, which is a imaging marker of coronary inflammation. And this is the pathophysiology behind it. If you have an inflamed coronary artery, it's going to release cytokines that diffuse to the perivascular adipose tissue, where they cause inhibition of local adipogenesis. And as the fat cells die, there is more spacing between the fat cell, and that shifts the Hounsfield units to a more positive value closer to 0. So lipid usually has Hounsfield units of around negative 190. And as you have inhibition of adipogenesis, that's going to move closer to 0 up to negative 30. And this was their landmark study from Lancet in 2018 called the CRISP CT study, where they calculated these fat attenuation indexes along the proximal left main, RCA, LAD, and left circumflex. And just it's important to know how to define perivascular fat. So they define it as fat within a radial distance equal to the diameter of the vessel. Beyond that, it would be counted as epicardial fat. And they applied these indexes to these two cohorts, the derivation cohort, which was out of Germany, and then a validation cohort, which was out of Cleveland Clinic. And they showed that high perivascular fat attenuation index values, they came up with a cutoff of greater than 70.1 Hounsfield units are indicator of increased cardiac mortality, which has implications for measuring it to guide our primary and secondary prevention strategies. So Dr. Antonides at Oxford has really led the work worldwide in this field. This is a nice review from him in European Heart Journal, which talks about the PVAT or perivascular adipose tissue as a biosensor of vascular inflammation with bidirectional interplay using paracrine signals between the vessel wall and the fat in the perivascular space, which affects the vascular health in terms of vascular tone, the redox trade, enos coupling, endothelial cell activation, inflammation, and smooth muscle cell migration. So PVAT is not just a source of imaging biomarker, but it's also a therapeutic target. So you can follow it over time to see if some of the treatments, whether statins or emerging treatments like colchicines and EPA, are making a difference. And they have come up with this device called the Carry Heart medical device that integrates information from the fat attenuation index, and there are percentiles available for that. With quantitative plaque analysis, integrates them with the traditional cardiac risk factors to come up with the risk of future events for a patient, hence making CT really a one-stop shop for everything. This is the company Caristo, which is a spin-off from the professors at Oxford who created this technology. And this is a sample report from their website where it's gonna give you percentile of your overall FAI score, and then give you a carry heart risk score, what they're saying, which is 4.6% risk of an event in 8 years in this particular report. These are color coded, with the red being the areas of high perivascular inflammation. And then in each of these 3 arteries, they'll give you the FAI scores with the percentile. Finally, I'm going to talk about this one area which may be debatable today, but I think has a lot of promise in future, which is using coronary CTA for primary prevention and really changing the way we think about utilizing coronary CT. This is a nice review in JCCT about it, 2012. And here are the important points. We all love using calcium score. It's easy, it's cheap, and does have tons of data for its prognostic value. But it is a good rule in. If you have a score of 0, it does not necessarily rule out disease, especially in younger patients. I showed you the recent data showing that younger patients less than 45 may have a higher proportion of non-calcified plaque. Up to 1/3 of patients in the MESA study who had events actually had a calcium score of 0. In the coronary artery calcium consortium cohort, 43% of patients with cardiovascular death actually had a calcium score of 0. So where does that lead us? We know that low attenuation plaque is the strongest predictor of coronary events. And then the argument for CT for primary prevention is much stronger than before with all these newer technologies that I've just been showing you, the advanced plaque analysis, which can be done in the order of 5 to 6 seconds using the deep learning models, FAI scores, and emerging data from radiomics. There is an ongoing trial, the SCOT-HEART-2 trial, that is looking at primary prevention in asymptomatic patients with at least one risk factors. And the way I think the field is going, this is just a matter of time before it gets wide. This may be debatable today, but this is just a matter of time before this gets widely accepted to do CT in anybody with 1 or 2 risk factors, with eventual public health impact, basically equivalent to vaccinations, which when you look at the burden of coronary artery disease worldwide. And I'm going to end by showing you some of the research we are starting at Houston Methodist. I've always had a big interest in coronary artery disease in South Asian population. And really, with all this technology, the time is now for cutting-edge translational research that incorporates coronary CT for deep phenotyping. So our study is looking at the association of plaque burden and morphology and coronary CT angiography with proteomic profiling and genome-wide genotyping in South Asians living in the US. The 2 aims of the study are to identify proteomic and genomic markers associated with plaque burden, plaque morphology, and coronary CT in a South Asian population. And then to see how that those markers correlate with lower cholesterol efflux capacity assay. That's an assay that's been developed by Dr. Dan Rader at University of Pennsylvania, but it's never been studied in this context in a South Asian population. Here's the study design. It's an observational case control study where we're going to recruit South Asian men and women. They're all going to have proteomic profiling done using SomaScan. Their latest actually can now do 11,000 proteins. They'll have whole genome sequencing done, lipid profile, cholesterol efflux capacity assay, and then plaque quantification and morphology. We are partnering with Lucid, one of the software companies with this. But you can see, with the radiomics, the FEI, the field is just going and going. There's so much you can do in terms of deep phenotyping for any such kind of study that you undertake. And the paper talks about this, our grant talks about this concept of protein quantitative trait loci. And basically the thinking is that you have a genetic variant called a PQ2L, which has been known to be associated with coronary artery disease risk from prior genome-wide associated studies, and is also associated with elevation of a protein biomarker when you do the proteomics analysis, and is associated with high-risk plaque features, deep phenotyping on CTA, that argues that this gene to protein is part of the pathophysiological pathway, and this elevation in protein is not just a random biomarker elevation in blood. With that, I will end. Thank you very much. And happy to take any questions.
Thank you very much, Walid. That was fantastic. I'd like to bring back now Kamu and also Yasmin.
Walid, thank you very much. It was really great, a wonderful overview. I have a couple of questions. With the time and the cost associated with FFR, typically it costs about $1,000 to $2,000 as an add-on. The downstream cost can be tremendous if you use it more as a screening tool rather than use it just for very specified populations, such as where there is diagnostic uncertainty. I would like to get your thoughts about that. And a second question that I had is about the post-processing time, which typically takes anywhere between an hour to 4 hours for the post-processing to go to sit at a station and then do this, which kind of needs to get better, I think, in my opinion, for it to become more widely utilized. And also, a lot of the studies, I always kept thinking back, if you think about PROMISE study and you think about some of the other studies that have come out, most of them are in the low 300 range of patients that they've actually looked at. So that is also something, how much we love data in cardiology. So those were two of the questions, and I'm going to share my last one for later.
Okay. So one of the main roadblocks to CTFFR is the way we do it today with heart flow is definitely logistically with the time constraints that we all have. And at Houston Methodist, we have a very high CT volume. You could be reading 20 to 25 scans a day. So it's impossible to request it and then wait a few hours and you may not even remember to go back it. So what they have implemented is a system where every study that is done is automatically sent to HeartFlow for CT-FFR analysis. And then when you log into your account in HeartFlow, you have to click if you accept the charges and if you want it. And when you click that, it's there right away, especially unless it's a difficult case. So that's how we have gotten around the logistical issue. That is also the reason why these newer models of CT-FFR that clearly gives you, for example, that are based on anatomical data, these deep learning models, and I showed one paper talking about that, how it matches really nicely with the one with computational fluid dynamic analysis, are really attractive because these can be at your local workstation. You're not dependent on a third party, and it'll also make it cheaper, right? Because it's just the initial cost of having that software and not have to pay, for example, HeartFlow every time for it. Now, although it is, I think, reimbursable, and they have to know, the CT managers have to know how to bill for it. So that those are definitely the challenges. Now, the data for CT-FFR in the trials that were done for testing clinical efficacy of CT, whether it's PROMISE or SCOT Heart, only a minority of patients had a CT-FFR, even in that precise trial that talks about utilizing CT-FFR as a gatekeeper. Only a minority of patients had this. So that is a limitation, because we have data on CT-FFR on thousands of patients from the advanced registry and so forth, all those studies that I was showing you in the table. But those are all like, how does CT-FFR correlate with invasive CT-FFR? They really don't have a lot of outcomes data. And that is a limitation. But I think this is just going to make it much more easier when we have this at our fingertips at the workstation, especially if that one is just as good as the one with computational fluid dynamics.
Yeah, my question that I was saving a little bit is about the efficacy in the setting of somebody who has had bypass grafts and also anomalous cores. I know the data isn't still perfect in this subpopulations. What are your thoughts about it?
Bypass graphs, it is not going to work. So the algorithms will just kind of fall apart, because they're really trained to first construct a normal 3D coronary anatomy tree. So even if it's an anomalous artery, it may pick it, or it may be thrown off by it. Bypass graph, we don't use it. Stents, like I mentioned, we can still use it in the non-stented vessels. But one other big limitation that I didn't talk about is if someone has a very high calcium score and there's a lot of calcification, like calcium score of 1,000 plus, a lot of those studies will get rejected, because their algorithms are dependent on having a clear center line in the lumen. And when you start to have severe calcification with looming, that kind of just goes away. So it'll just come back to you returned. So it doesn't always work.
Thank you. I'm going to turn it over to Yasmin. I'm sure she's got some burning questions as well.
Hi, thank you for an amazing talk. We appreciate the overview. Just a few questions. It's an exciting field for all of us, and of course, I do personally believe that CT plaque analysis is the future of cardiology. One thing in relevance to Dr. Maganti's question about FFR, I see quite a bit, and I'm sure you have experience with that. As we know in trials, a lot of studies with CT FFR, there was reduction rate 12-13% because of image quality. Now in real life, I've seen, one of the questions that comes from other physicians is, why don't we bypass you guys? And I just want to go ahead and order a CTA FFR, right? And then we always say, no, we want to look at the images first and set it for FFR, because a lot of times you get abnormal FFRs and the image quality is really bad. Despite knowing the quality is bad, you get the FFR results. So what is your experience with that? Following that, I have a couple more questions after you answer this.
I think I would not advocate for a strategy where they're going automatically without us first judging when it's needed, we being the expert readers. Because even with that 30 to 90% range, honestly, if it's clearly 90%, I don't want to request it. I know it's, even if it's come back normal, am I comfortable saying, oh, don't take this patient to the cath lab? Probably not. And if it's clearly 30, 40%, I know it's not going to be significant. So I use it as a tiebreaker more in my moderate 50 to 69, 70% range. But it shouldn't be something automatic. We've had some, our system is big, so we have a lot of private groups that are not part of our core faculty refer patients to us. And a lot of time they will insist the same thing, that I just want a CT FFR on patient with a calcium score of 2000, because I just really don't want to cath this patient. And they have to understand the modeling is just not going to work. It needs that center line. This is not magic. It's not going to work for us to read it because of the looming artifact. It's not going to work. FFR heart flow is going to reject it right away. And at some point, really, your clinical judgment comes into play. So I know we have those kind of requests, but we have to use our judgment.
Yeah, no, that's true. And nicely answered. A couple of more things. So, the power of zero, we all talk about it. So in future, what are your thoughts? I feel like, we have gone beyond that calcium score, non-contrast CT, and we should all be using CTA with all the different things that are available, fat attenuation index, the plaque analysis, things of that nature. But there is a whole bunch of data on calcium scoring. What are your thoughts? That's not going to go with the data is what it is. If you ask Matt Budoff, who's my mentor, he's going to say, no, Yasmin, forget about it. Calcium score is the thing to do. So what are your thoughts?
Yes. No, thank you for asking that question. I think about that a lot. And, I work at Houston Methodist. I work with Khurram Nasser. You may know him. So his topic of every talk that he gives is the power of zero. And that's what he's talking about. But here is the problem, right? All the prognostic studies of calcium scores, and there are many, many, right? They start with showing you patients with higher tertiles of calcium score having adverse outcomes, right? And the patients with score of zero having low event rates. But the problem is a lot of these studies include older patients, and those patients, within those patients with a score of zero are buried a lot of younger patients who actually are not zero. They're more likely to have low attenuation plaque. And if you look at the cost, economic cost to the society, that's going to be the bigger impact, preventing cardiovascular disease and death in those younger patients. And that's why, especially in, for example, my interest in South Asian population, they tend to have a lot of non-calcified plaque. I do not trust a score of zero in a 42-year-old South Asian male. I want him to have a full coronary CT. And I think the data has to show that over time. We are just in the beginning stages of that. Michelle Williams started the Scott Hart 2 trial. There was one other trial, I'm forgetting the name, I think it was called CAT 64 or something, that looked at primary prevention. It only had 900 patients, but the problem was they recruited patients with diabetes who were already on a statin, and then they showed that doing CT doesn't improve outcome. Well, there was no room for the imaging to change your management decision because you're already taking patients with the CAD risk equivalent diabetes, right, who are already on statins. And then 900 patients is not going to be able to show this, right? So this is for public health impact, you need thousands and thousands of patients. But that is really the field is going. Calcium score is not going to be enough. Maybe in older patients, yes, but in a lot of younger patients, no.
Yeah, and in follow up with that, another question, so yeah, we do think that CTA is the future. Now we talk about all these trials and, forgetting about the patients they've excluded. But in real life, if I were to do high risk plaque assessment, if I were to do plaque quantification assessment, we know that unless you have that software available or machine learning is readily available and you have the best image quality and you can totally trust what you are analyzing. Any of those plaque softwares, like I have experience with Vitria, and it just counts the vessel wall as plaque, and then you are giving results that are inaccurate. So we are, getting all these AI-based platforms. So again, for currently, the only FDA approved is clearly and HeartFlow. For I'm sure they've got approved from FDA for plaque analysis. So these are limitations that comes in your way. Go ahead.
So this is, like most fields in AI, whether it's applied to radiology, thoracic, there's an intense competition, whether it's neuroradiology, thoracic radiology, cardiac radiology, right? And within all these vendors, there are going to be some winners. Not everybody is going to have the data to trust. And I'll give you an example. HeartFlow knows that all the other vendors are doing it. So they have been, other than, of course, their FFRCT, they have been trying to come up with their version of plaque quantification software. And so they gave it to us as a trial because Houston Methodist was one of their trial sites to test there. And it wasn't good at all. It was picking up plaque in completely clean coronary arteries. Um, And clearly, on the other hand, we haven't used it. They've given us a number of talks so far to see if we want to implement it. But their data seems to be good. And I think, and they are doing larger studies, partnering with institutions to do larger studies. In fact, they're doing a much bigger study now, partnering. I think Dr. Deepak Bhatt is the PI for that at Mount Sinai with them, and that's going to be to see how the plaque characterization using clearly and their FFR correlates with outcomes. So the winners are going to be the companies that have the resources to conduct these bigger studies to actually show the data, not just come to us and say, oh, this is a plaque analysis software that we develop, and then you deploy it and it just doesn't work, right?
Yeah. I just wanted
Yeah.
to have a quick question about two other advances. I wanted to see if you had any experience with photon count CT and its ability to better characterize the plaques, number one. Number two is the role of perfusion. I think there's been some experimental studies with CT on looking at myocardial perfusion. Particularly, I think I get often patients, I mean, the plaque quantification and the power of zero. This is all good for younger people, but you have also those people who often come in who have an existing burden of coronary artery disease. The tropes are negative. The patient comes in with chest pain, and then you're looking for a method to understand which artery to treat, where to go. Maybe we just do a perfusion testing or exercise or another nuclear, something else, echo. But it would be very handy if you would have, let's say we discovered, okay, you have all the, large coronary calcification. Maybe the perfusion could come handy in those situations because you cannot look into the
Yes.
the quantification of the plaque because of the blooming and other artifacts.
So CT perfusion is absolutely an evolving technology, and I was initially going to include a few slides to show the current data where it stands from CT perfusion, but I think I was going to run over time. But there is a group out of Italy, I'm forgetting the last name of the author. They have really pioneered a lot of the studies about CT perfusion. And they advocate a protocol where you do the resting CT scan, then you give the adenosine, and then you do the perfusion imaging. The challenge, and their data has been very good, everything that they've published. The challenge and its widespread adaptation is that you have to set, one, there is radiation dose that is higher, at least twice what you would get with just the regular CT because you're doing 2 scans. And then the second is the scan parameters have to be set very carefully. The contrast rate, the density of the contrast, because you have to see the perfusion just like you see with MRI, the perfusion going through the myocardium. And then you need to have the software that can clearly do it. And if, of course, the images they show in the papers are really nice and clear, but if it's not done perfectly, then and not every CT lab has the protocols and has been comfortable doing it. I think that has been the limitation, but the data from them is very good. And of course, with people with multivessel disease, heavily calcified plaques, you're absolutely right. Above and beyond CTFFR, it'd be really nice to know where is the perfusion defect, rather than putting the patient then through another study with a PET and trying to see if that matches. And then your first question, our experience with photon counting CT, we haven't been, Methodist wants to be the first in everything, but in this scenario, they have fallen behind a little bit. So our photon counting CT is getting installed in October of this year. So personally, I have not read any cases yet with that. We're looking forward to it. The papers look good, like the images I showed you from the paper in radiology. The biggest excitement is because we get referral for very complicated cases, the stents, grafts, a lot of patients with high calcium score. Even though we keep telling the referring physicians it doesn't work when the calcium score is very high, but still we keep getting those. So it's supposed to help with all of that. But I will say that I am also being cautious as referring physicians are coming and asking us when is it coming. That again, this is not going to be magical. If you have a calcium score of 2000, I don't think it's going to get rid of the blooming artifact completely, and you may still be wrong and call, lesions as stenotic that are not. So we'll see what our personal experience is, but it's exciting that we will be getting it.
And I'm just going to ask one last question. What's your experience with FFR CT planner? Have you used it?
FFRC.
PCI, I'm sorry, the PCI planner through the heart
We
flow.
don't
Have
have
you
it.
used that?
We do not have it. So that's something, I was reading the paper about it, and it's very exciting. And you need to have a specialized software as an add-on that some vendors are selling. I think Vitria has an add-on for that. We do not have it yet. It's not on the radar of our interventional cardiologists, so they haven't pushed for it as well. I have seen case reports about it, including sort of that one picture from the review that I showed. But I haven't really seen any big studies, with a series of patients utilizing that approach to see how it affected what they did in the cath lab yet.
Yeah, I think Kamu, you can close.
Yeah, I was just looking to see if there were any other questions. I mean, if you just had us between Yasmin and I think we'll have a lot more questions, but thank you so much. The whole thing and the questions were fantastic. I've learned a lot. And we hope to see you soon.
Thank you so much for the talk.
Thank you, Walid. Everybody have a great night.
Have a good evening, everybody.
And if you haven't looked at the mock points and stuff, everything regarding the CME credit as well as the mock points are in the chat. And it's also available on YouTube. So thanks again, Walid. Have a great evening. Bye.
Bye.